Good morning, everyone. I'll be talking two basic talks, one on gonioscopy and the other one on a laser peripheral iridotomy. So the first one, gonioscopy, is a procedure for evaluation of the iridocorneal angle in terms of both structure and configuration, utilizing gonio lenses. The term was first coined by the Greek ophthalmologist Alexios Trantis in 1907, with the term gonia meaning angle and scopin meaning to observe. The first ophthalmologist, however, to use a contact lens to visualize the angle was Maximilian Salzmann in the early 1900s, both of which are considered the fathers of modern-day gonioscopy. So we are unable to view the iridocorneal angle unaided because of the fact that the light rays that emanates from the angle strikes the corneal tear interface at an angle that exceeds the critical angle. Therefore, it is totally internally reflected. The way to overcome this is to use, during gonioscopy, we use lenses to change the interface, therefore overcoming total internal reflection. And what we do is we use gonio lenses for direct viewing. They're thick, convex lenses, or we can use gonio prisms or mirrors for indirect viewing. There are several types of gonio lenses depending on what you want to use them for. The direct lenses, there's the prototype KP lens, which is a prototype diagnostic lens. It has different sizes for infants and for adults. And then there's the Barkan lens, as well as the prototype surgical lens being the Swan-Jacob lens. So all these direct lenses can provide an erect view of the angle, very panoramic view, and you use a microscope or loupes to examine the angle with these lenses. So you really require the patient to lie supine. So most of the time we use this to do this in the OR setting rather than the OPD because it's quite inconvenient to have all the patients lying flat. Indirect lenses, we've got the small diameter lenses and the large diameter ones. The small diameter are used for indentation gonioscopy. The prototype indirect small diameter lens is the Zeiss 4 mirror. There's the Posner lens and the Sussman 4 mirror. And then the large diameter lenses, we've got the Goldman 3 mirror, the Goldman 1 mirror, and the trabeculoplasty lens. With the large diameter lenses, you've got a large surface of contact between it and the cornea, so you need to couple it with using a coupling agent with methylcellulose gel. This can degrade imaging after gonioscopy as well as perimetry. All these indirect lenses are convenient to use. You have a patient erect at the slit lamp. You have an upright, the patient sitting upright, as I said earlier. You get a high quality view with the slit lamp, and you can change the illumination of the slit lamp to visualize different structures. However, you need to remember that you're actually viewing 180 degrees away from what really is viewed, and inadvertently you can cause the angle to deepen or shallow depending on what you use. So if you're using a small diameter lens and you press too hard, you'll indent the eye, you'll inadvertently open the angle. And if you're using the large diameter lenses and you indent too hard, sometimes you can even shallow the angle with those lenses. The uses of gonioscopy, this is part of a comprehensive eye exam. So every patient coming to the ophthalmology clinic needs to have at least one gonioscopy, especially before dilated fundus exam. Particularly ocular hypertensives, glaucoma patients, glaucoma suspects need to be evaluated and their glaucoma classified according to whether it's an open angle or closed angle and whether it's primary versus secondary, and in particular angle closure glaucoma, whether it's appositional or synechial. You also use it for therapeutic purposes in trabeculoplasty, doing an SLT or an ALT, also iridoplasty, laser iridoplasty. And the intraoperative use of gonioscopy is really now on the high with the advancements in the MIGS procedures and goniotomy with congenital glaucoma, as well as goniosynechiolisis. Post-operatively, you'll use gonioscopy to examine an ostomy post-trabeculectomy, and also if you need to perform a goniopuncture after deep sclerectomy, you would need that. Prognostically, you would evaluate the PAS and how they're progressing with time, so gonioscopy is also essential for prognostic purposes. So the normal anatomical structures of the angle are viewed here, and usually we would go from anterior to posterior here in this case. Schwalbe's line is the termination or posterior junction between the posterior termination of Descemet membrane as well as the anterior trabeculum where they meet. That's the Schwalbe's line. It's usually an opaque line. You can't really visualize it in the normal angle in a lightly pigmented eye. However, sometimes you have deposition of pigment at or anterior to Schwalbe's line, and that would be known as Sampolesi line. If you cannot visualize Schwalbe's line, or you have difficulty with that, the way to really detect where it is to use the corneal wedge technique, where you off-center the slit beam, creating two light reflections, corneal light reflections, and they meet at the point of Schwalbe's line. Posterior to that, you've got trabecular meshwork, which runs from Schwalbe's line to scleral spur. There's the anterior non-pigmented part and the posterior pigmented part, which is in charge of the aqueous outflow through that, so it becomes pigmented with age. And then deep within the trabecular meshwork is the Schlemm's canal. You usually can't visualize it in the normal eye. However, sometimes you could have efflux or egress of blood in Schlemm's canal if you have a high EVP case or a case where there's a hypotony. Scleral spur is really the anterior termination of the longitudinal ciliary body muscle where it meets with the posterior trabecular meshwork. And then posterior to that, you've got the ciliary body, which can be variable in pigmentation, as well as the iris root. So there's several grading schemes for the angle in terms you use this for communication, for future reference purposes. The original one was Shea, which was based on structures visualized. They graded from 0 to 4 according to the degree to which the angle was closed, so 4 being the most closed angle. Schaefer was the opposite, from 0 to 4, with 4 being the most opened angle, and it's based on the width of the angle recess. Spaeth, however, used 3 parameters to grade the angle: iris insertion, both pre-indentation and post-indentation, angular approach from 0 to 50 degrees, as well as peripheral iris configuration, which we found very helpful to be very descriptive in terms of these 3 parameters. Now, if you don't see posterior trabecular meshwork, or you don't see any structures, you need to really differentiate between appositional versus synechial closure. And you perform what is known as the indentation gonioscopy or compression gonioscopy, which Dr. Smith earlier provided a video of that. So what you do is you provide direct pressure with a small diameter indirect lens, directly perpendicular, applying pressure on the cornea, and that would displace the aqueous and cause the aqueous to divert into the angled recess, thereby pushing the iris flatly backward. And if you can actually open the angle if there are no synechia, that would be appositional closure. And if the angle does not open, then it's likely that there's peripheral anterior synechia there. So as you can see in the images top left, you have a pre-indentation image of the angle. You don't see any visible structures. Bottom left, you would see the indentation gonioscopy presenting with appositional closure. You see the structures now opening up with indentation. And the bottom right, you would see tent-like adhesions, which are peripheral anterior synechia with indentation. So some clinical pearls: you keep your goal in mind, you comfort the patient, you perform the testing undilated, with an undilated pupil after testing vision and pressure. You would center the lens not to cause any sort of distortion with the patient in primary gaze position, because that's you want the natural position of the angle. You apply the right amount of pressure, and with a small diameter lens, you really can see the bubbles darting in and out. That's a good sign. When you see corneal folds, that means you're pressing too hard. Low light conditions should be used, so you darken the room and you use a short, thin beam. So you really don't want to constrict the pupil and open the angle. You look for landmarks, as we said earlier, the corneal wedge technique, and you perform indentation gonioscopy, as we said, when needed. You describe the angle in any way that you find useful. You don't have to follow the grading schemes. It is helpful if you know one of the grading schemes, but you can describe what structures you visualize, where's the iris insertion, what is the pigmentation of the angle, if there's PAS or no PAS, and so forth. And obviously, you perform this test periodically on your patients. And practice, practice, practice. So we do agree that gonioscopy is the oldest method to evaluate the angle. Its value is evident. However, it's underutilized. A lot of times we go to the clinic and realize the patient hadn't had even one gonioscopy done. Studies have shown that less than half of POAG patients had a single gonioscopy procedure during their initial glaucoma workup. So I think it's because we rely a lot on alternative methods to assess the angle status, like anterior segment imaging, either UBM or anterior segment OCT. But we have to keep in mind that with gonioscopy, you're actually visualizing the entire anterior chamber angle. You're seeing it in true color. You're seeing pigment, neovessels, hyphema, anything of the sort, which you can't really tell with all those high-tech imaging. It's inexpensive, it's quick, it's inconvenient, it's widely available. Sorry, I didn't mean inconvenient, it's convenient. And its application is unique in terms of indentation gonioscopy. So it stands as the gold standard till today in the hands of a skilled practitioner.